Okay, cool. Hi, everybody, and welcome to the Mobile App Challenge Colloquium. Just a couple of words before we get started. I'm Warren Streaming from IT Services, and I think I know most of the people, but not everybody. So the Mobile App Challenge is in its third and final phase. It's really been a great experience this year, a terrific partnership between IT Services and the Polsky Center and UChicago Tech, and right now the three finalist apps are in the process of being coded by our student interns, and we will have the grand judging and awarding of the prize. When is that?
May 30th at 3 p.m. in room 104 in Booth.
So please try and make that if you can, May 30th, right here in Booth. And in 2 weeks, we have another colloquium right here in this room with Robert Morrissey, who's going to talk about the French Encyclopedia app that he's been working on and was just received rather rapturously in France for the 300th anniversary of Diderot's birth. So please come and hear about that. And yeah, and we'll do more of this next year too. We've been working with Melissa Gilliam on a whole range of activities for the past couple of years, and they've all been really fascinating and tremendously exciting and really fun. And this was just one of them, but it plays really strongly into the mobile app challenge world. And so, without further ado, Melissa is going to tell us about it.
So first of all, thank you so much for coming. And what I wanted to do today is divide this into a couple of sections. The first is I was asked to talk a little bit about my work at the university. Then I was asked to talk about sort of the context for developing this app, and then to show you the app and then take some questions. So we'll get through all of that. I wear a lot of hats at the institution. So I'm in the BSD, where I'm a pediatric and adolescent gynecologist. I'm the chief of family planning, which was that big logo up front. I'm also the dean for diversity. And on this side of campus, I had an interdisciplinary center in sexual and reproductive health. Now, I know you're like, oh, well, your kids must be a mess, but, it all kind of works and fits together. So, but what I want to do is tell you a little bit about some of that work and kind of my philosophy of research and life and what drives me, and then sort of tell you how I got to this developing an app to represent that. So as a physician, I have to have kind of a public health or driving clinical issue. And so these are the numbers that kind of have always excited me and enticed me, and why I became an obstetrician gynecologist. One is an incredibly high rate of sexually transmitted infections that are particularly high in my population, which is young adults and adolescents. And that number, these 15 to 24-year-olds are at particularly high risk. And this is another way of looking at it, and why it's particularly interesting to me to look at these issues in Chicago, which is, so the key to this map is darker is worse, and Illinois is darker, and most of that is driven by Chicago. So really high rates of chlamydia in Chicago. And you can also, again, sort of see that it's really my constituency, young girls between the ages of 15 and 24. So that's one major public health issue that relates to sexual and reproductive health. The next one is teen pregnancy, and that has become that's always been a long-standing issue, and it's not a hard conceptual leap, because as a resident you deliver babies all of the time, and once you've delivered enough babies to 13 or 14-year-olds, you say, oh my gosh, this is a problem. And so that was one that has always struck me. The good news is that we're doing better in terms of teen births. These are the most recent CDC data. And what you can see is that with each year among all teens, we're really doing significantly better in terms of the number of teen births. But again, these have been the public health issues that have driven my work. Typically, when you look at these issues from a policy perspective, we kind of come up with these very simplistic formulas, like, okay, we'll just say abstinence only. And that really did very little to drive down the teen birth rate. And when I thought about kind of what the most effective ways of approaching those would be, I realized, you know, it's not really the risk behaviors that interest me so much, it's the kids and watching them grow up. And if I really asked what I was interested in, it's kind of getting them to college, because once they do that, their economic and other outlook is much improved. And so, so instead of just focusing on risks, I'm pretty interested in thinking about individuals within larger systems. And so that's how I link almost everything I do, from diversity to my clinical work to developing a center. Because what all of those things allow me to do is think about both the systems and areas in which we change systems, and then also the individuals within those systems. And so I'll kind of come back to that framework. And it makes a lot of sense. If you think about human development, you have an individual who's within kind of a family, a neighborhood, a community, and society. And so in health, we think about some of those systems as health disparities or economics or other social structures that may affect human behavior. And then in my work, in my center, I work across lots of disciplines. I work with economists, I work with people from Booth and from other departments, really some addressing the systems level and some addressing individual behavior. So what that's led me to is research that looks a lot more like this, where you have, this is some of the work we do with adolescents, where when we think about how we're going to address a problem, we actually include the people who are most affected by those issues in the process of developing the research and the interventions. I would say probably the first 10 years of my work was trying to describe problems, and then most recently it's been more trying to fix problems, always with a strong focus on contraception, which is a pretty good way of fixing problems and a pretty direct intervention, but now thinking a lot more about developing behavioral interventions. And so these are a few more projects that we've been doing specifically around using games and game designs as a way of creating interventions with youth for youth. And that's another process of a picture of us at work. So that's sort of the background. That's at least a snapshot of some of the work that I do and some of the approaches that I take to this work. But I wanted to talk to you specifically about developing an app and how that came about. And I was asked to let you know that I did this as also in context with the app challenge from last year. And so we came in second place for this, and this is the process of us building it out. So this is a study that we are conducting right now. It's an R01 that we have to look at the systems of care in 3 clinics on the south side of Chicago, serving predominantly a low-income population. And so what the grant does is we look very systematically at all of the processes of care in order to provide the intrauterine device, which is a particular contraceptive method that works pretty well, is highly effective, but is kind of underused. And one of the reasons it's underused is for some historical reasons, but it's really one of the most effective methods. And so if you go back to my talk about teen pregnancy, if in a clinic a person can come and actually get the method that they asked for, then they have really effective pregnancy prevention for 5 years. And this is particularly important for adolescents. And so the goal of this research is to think not only about what we typically say when someone comes. It's like it's an interview between the doctor and the patient, and then they go with whatever they want. What we realized is that there are actually a lot of times when systems fail to provide the desired outcome, and that we have to actually fix those systems. And so we actually took a methodology that was developed in other high-risk industries, not that healthcare, not that outpatient service delivery is that high risk, but this idea of systems having failures comes from the nuclear industry, It was then taken into the car industry. And in these processes, people get teams together, anybody who's involved in the system, and you carefully march your way through and find any process and understand the process and then identify where it fails. And so this is a picture of a process map that we created in these 3 clinics. We created individual ones for each clinic and then we aggregated them. And this is, we worked with patients, healthcare providers, clinic staff, the people at the front line, and then we went back and got quantitative data to either verify or disprove that these were the failure modes. The next step is a process called risk bidding. And the idea is, if you ask me on any given day what's wrong with the University of Chicago Medical Center, I'll tell you the thing that bugged me that day. And it's my perception, but it may not be true. And so what you need to do is actually weight things. You need to understand what are the most important factors, what are the least important factors, and how they affect your outcome. And so what we did is we put these into, you look at how common it is, and you look at whether there's a safeguard, right? So something could happen, but if I have a back-end fix on it, then I don't have to worry about its impact. And so we're looking at how important things are on their impact. And so you use this process of risk bidding. So there are a couple of things that we got excited about and thought these were right barriers for intervention. And the one I'll point you to is this one up above. The patient doesn't learn about the IUD during contraceptive counseling because the provider doesn't think she's a good candidate. Or else we found things that they didn't have enough time to tell her about all methods. And so we found a lot of the problems for women getting good contraceptive care had to do with that process of counseling. We found a few other places, and we also created interventions to address those, but I want to specifically focus on this area. So this is what led us to create a counseling app. And our idea was, if someone had this app that they could use in the waiting room, they could start to work through the process of counseling, and then by the time they arrived at their provider visit, they would be well informed. This isn't new, but it's usually just a pamphlet, and you're given a pamphlet and you're supposed to read it. What we found is that the patient said, if I'm sitting there reading this pamphlet and it says STDs, everyone's going to think I have an STD and I don't want to read it. If I have, contraception, maybe it's not so bad, but I don't want people knowing what I'm doing in the clinic waiting room. So for the most part, I just watch the TV. When we talked to the people who ran the clinic, they said, well, we're really busy. So if she comes in and she says, I want the pill, that's what I give her. But the data shows that most adolescents who start the pill actually discontinue the pill within 1 year. In fact, almost any method that they start, they discontinue. Versus, there was just a very large study in St. Louis at Washington University, and they showed that by providing the intrauterine device to adolescents free of charge, it was the most selected method by them. They showed that both the teen pregnancy rate and the teen abortion rate in the entire region both declined. And it was just published in the New England Journal of Medicine. So this idea of the provider being a barrier is really a problem. And the fact that this sort of lack of privacy is also a problem. And so we started to look at this idea of how could we use an app to solve some of these issues. So the idea is the insufficient client materials, problems with client counseling, and then lack of patient awareness. The other thing that you do when you try, so I've talked about systems, but the other thing that you try to do when you're changing behavior is to address the behavior in a theoretical way. So this is a schematic of a long-standing theory called the theory of planned behavior. And it says that one of the ways that some of the barriers to changing behaviors have to do with people's beliefs, their personal beliefs, their kind of community beliefs, and then their ability to control the behavior, and then these sort of attitude, subjective factors. And those lead into whether they intend to change the behavior and whether there's a behavioral outcome. And we work with one of the behavioral scientists in the medical center around a lot of this work. And so what it meant was, when we develop the app, it's not enough to just sort of focus on knowledge. We have to start to address some of these normative beliefs Sometimes these are values that are held by peers, by family members. We have to sort of their sense of control. Can I actually do this? Do I have the self-efficacy to adopt these behaviors? And so this framework became a way of us sort of thinking, well, what does this app have to contain in order to be effective? So we took a page from the playbook on transplantation, which shows that there's a great study that showed that when people were asked to become organ donors, if you go to them and say, look, I'm an organ donor, and then you have another family that says, I'm a donor recipient, just that those testimonials that show what it is in real life really helps disabuse people a lot of their fears. So this idea of an upfront testimonial about the behavior of interest can change behavior. And then we also wanted to create interactive informational pages about all method effectiveness. Is it effective? How does it work? Myths, fact, what to expect. And the idea here is not to persuade people beyond the behavior that they want, but at least if they don't want to do this, it's not based on incorrect information. And so, it's sort of a philosophy of mine with contraception, and especially long-acting, is we have to be really thoughtful about right-sizing it, right? The idea is not to coerce people and overuse something, but you also don't want to put false barriers in front of them. So the next step was usability testing. So we actually did this at the University of Chicago. We had 7 young women from my clinic who just went through and looked at the app and saw how it worked. And it allowed us to get information on the visual design, whether they understood it, how to navigate it, some of the organizational information. And we videotaped those and got feedback. And you can imagine we got a lot of help on this step. And these are some hands kind of working through the app and with some of the usability testing. This is another picture of usability testing. And this was really helpful to get feedback. And so for this we're drawing from principles of human-centered design, where you're going back and you're really trying to create a patient-centered approach to developing interventions. And so these were some of the things that we asked them. Tell us your overall impression. What do you think about the amount of information? Where would you click first to learn more? And so how do they actually use it? And then the next step will be to use this in a randomized controlled trial. So this goes into the field in the next few weeks. We're currently doing pre-post testing on a separate intervention we designed for the clinic, and next we do an RCT. So basically they'll use the app. It will give demographics. We'll assess something called stage of change, which is sort of the readiness to adopt a behavior. They'll view the choices apt, and then they'll go through counseling, and then we'll chart to see what method they adopt. So this is our team who works on this particular project. It's being done at Planned Parenthood of Illinois, and it's funded by the Office of Population Choice. So do you want to show the action? Do people have questions?
The use of technology present any barriers in the clinics? Were all the young girls comfortable using this technology?
Yeah. So so the earliest usability testing we did was all paper and pencil. And it actually, the initial ones weren't, we didn't use Wi-Fi, so the app didn't directly link to, wasn't completely put together. So what we did was we did paper and pencil. We created some rough prototypes. Some things they actually had to go to the internet for some of the informational things. So we're like, so if you went here next, would you be okay? They completely got it. So the technology part was really intuitive. I think it's because we work with such young people, so it's all teenagers and young adults. This is how the interface ended up. I'll probably hit a wrong button. So people they were interested in this idea of trying to help them understand risk. This is a big thing in medicine, is that many people are very quantitative. Well, I guess it's, I think people talk about innumeracy throughout life. So, but this idea of how do you actually understand risk and how do you understand risk in medicine? There are some people who think we over-counsel regarding risk. We tell people too much, and other people think we tell people too little. And so what we wanted to hear from people was, how do you want this represented? So we wanted to try to give them a sense of effectiveness, because this is really, I think this is the main sort of way that people can understand how to compare methods. This is based on a study done by the World Health Organization, which said, people don't like these little numbers about how many failures there are, but if you can start to give them some type of graphical representation, then they can start to order these things in terms of risk. I will tell you, I showed you those initial numbers about the falling rates in teen pregnancy. Most of this was driven by condom use among young men. And so one of the next iterations is really trying to think about portraying this as dual method use, both condoms and a highly effective contraception. And so that's sort of a future step for us. But this seemed to be very important to young women. They wanted to see each of the methods and have them described individually. And then we had one of the people who works on graphics for some of our other projects draw each method for us. And then the next piece was they wanted to hear from young women, and this goes back to what I had talked about in terms of behavioral theories and testimonials. So we had users of the method. They came. We did a little bit of, we sort of looked at the behavioral theory, and we identified the things that needed to be addressed. And then we kind of created the questions, and then we did some cutting and pasting and editing of the videos to make them short. And so, I don't know if it could work. I don't think we're attached to volume, but, oh, you did
that. I actually talked to my mom about it. My mom didn't know much about birth control. I started asking a couple of friends. I started doing research on it. I mainly was looking for long term, looking for something that was hormonal free. My main concern was gaining weight after having my baby. That was my main concern. So what I did, I just started Googling, IUDs. I started looking at hormonal free birth control. The first thing that actually popped up was the IUD. Cool. And I started looking into it. I know some of the reviews on Google, they were kind of scary because a lot of girls were pretty much just, false advertising on there. And I decided to take the risk and just try it out. I actually was scared. The thing I was mainly scared about was actually feeling it, if it would get stuck.
So that kind of gives you a sense. We could have made a perfect, beautiful, polished one. We could have scripted or used actors, but we thought it was really important for young people to hear from their peers and people who were very similar to them about their actual experience with the process. And then this was the second.
Hello, my name is Vanita Cobb. I am currently using the birth control method called Implanon. I've been using it for 8 months now, and I like it. It's very convenient because having a daughter and she's still young, and I walk in, I have to carry her to the doctor if I was getting depo or taking a pill, and I wouldn't always remember because I don't think any teen remembers. They barely remember their homework, so I think they're gonna remember to go to the doctor every 3 months or take a pill every day. And with Implanon, you get to go every 3 years. I chose Implanon because I really don't like shots, and with the Implanon, it was just easy. Instead of just keep going back and forth through the winter to the doctor, taking a bus and doing all that, and then waiting for the prescription. With Implanon, it was an easy process. They just ordered the prescription while I was pregnant, so I was ready as soon as I got home. And then they.
So that kind of gives you a feel for the approach we took. So this allows people to compare their options. And so you can click on each of these and it'll take you to information about it. One thing that was interesting is they wanted to know what will he think. And so each one goes to that screen about what your partner would think. And that was something that came out of the usability testing. I've talked to colleagues and I've done a fair amount of qualitative work in this area, and this was a newer one for us. And then this is a kind of a what can I expect? And it goes through each one about kind of what it is from the woman's perspective, and then how does it work. And so this will go through and talk about condoms, and you can do that for each method. So this is the pill. So we only did the video for the 2 long-acting methods, and then the other ones are these more straightforward, just graphical. And so you can do that for each of those.
Melissa, did you think about doing videos for the what will he think section?
We did not. I would say kind of 2. We did not. So part of what the study is about is sort of thinking about the longer acting methods, and so we kind of focused our limited resources on developing videos for those things. But that could be a really important next step, and especially if we're thinking about STI prevention, that could also be a really interesting step. I will say we just did a qualitative, and we're following that up with a survey of African American males on the South Side. I would, if I included those in the video, I'd be a little bit concerned. They were pretty dismissive of kind of birth control as being their issue. So I don't know what the videos would turn out like, but it's good thinking, and I think we could use a lot of videos in a lot of different ways. Anyway, so that's how it works, and then again, kind of this continuum, kind of helping them understand least effective, most effective. They can go through on the IUD and go through and ask all of those questions. Yeah.
In the trial, are you going to keep track of? Can you keep track of where people click?
I don't think we can, but it would be really interesting. We did that for the usability testing, so we videotaped it and kind of saw how people use it. And it led to a number of changes. Like, for example, at the beginning it said done at the bottom, and it meant done with the app, and it kicked you out, as opposed to what people thought was done with the page. So the videotaping did help. We also have a force function where we make people go to the videos. But other than that, I think we've tried to at least embed how we want people to use it within the way the app functions, but I don't think we'll be able to look at that.
Do you think the videos in the clinics will present a challenge from a privacy perspective?
Yeah, we've gone through this a lot. I will tell you, the clinics are in Englewood, Roseland, and Austin, and the biggest concern for them was that they would have legs and walk. So we've talked a little bit about like headphones and other processes, or else putting them in another room. But the actual logistics of this have been a pretty big part of thinking about how to put this into a clinic. I will say 2 things. One is there have been research on kiosks and kind of using health kiosks. And I think the future of this is that maybe you could download something like this on a phone before they ever come to clinic. If someone sort of says, this is what my visit is for, maybe you could just say, download my app, use this before you ever arrive. So I think we have to be creative about the flexibility of apps. But the people I know who've done research on kiosks say it's really difficult. There are a lot of technical difficulties. People are crowding around the kiosk or ignoring them. But that idea of how do we actually get it into a clinic is an important question. Yeah.
How difficult was it to convince the people providing testimonials? Because you share something very private and it goes public.
Yeah, it was actually incredibly easy to get people to do it. It's kind of funny. I think I think there's just a certain amount of altruism and and especially people who have gotten medical care. They often feel like, yes, this idea of I can help another woman like myself. they do it. So we have a lot of models of peers in healthcare setting, navigators. It's a surprisingly important and untapped resource, having other patients help patients.
So anecdotally, what has been the reaction so far from the patients?
So mainly it's been from usability testing, and it's been very positive. There's some, I think we probably have a little more work to do in terms of some of the navigating, but it's overall been very positive and it's been very clean. There was sort of another counseling program that was developed by a group called the National Campaign to Prevent Teen Pregnancy, and they worked with IDEO to develop this kind of much more comprehensive birth control counseling intervention. But I think what's been really nice about this one is that it's really been designed with a target population in mind, and that one I think goes a little bit towards kind of what we think people should know and what we think the ideal spokesperson should look like. And I think there's something appealing about the homegrown approach to the videos.
So after the trial, what kind of plans do you have to augment the app or change?
Sure. So we're developing a proposal right now to start to think about this in the context of dual method use. It's sort of the holy grail of reproductive health, is trying to prevent both STDs and pregnancy. And so these are really a series of very complex behaviors, and especially for teenagers, they can be complex behaviors. So our next idea is that we would build the app out to sort of talk about the continuum of pregnancy prevention behaviors and also STI, STD prevention behaviors. And so it becomes an app that might have resources for young men, for young women, really building self-efficacy in a lot of areas. There's sort of a concept being promulgated by the CDC called reproductive life planning, which is sort of saying, actually make a plan, be planful about all of these different things in your life. And so our idea is that we'll recreate the app within the context of this larger life planning. It kind of gets sort of back to this idea, instead of sort of looking at individuals from just risk and all the things they do wrong, kind of thinking about your real goal is that they grow healthy and well, and that you're focusing on their assets and what they want in their lives. And so that's kind of the next 2 iterations would be to incorporate this into reproductive life planning. And that's still not evidence-based, so the goal would then be to test that as well. And so that's and actually we just submitted that proposal to it's called patient-centered approach to research. So we just submitted that idea. So lots of things you can do with a mobile app challenge.
Do you have thoughts about moving it out of the clinic? It sounds like both of those things, this and what you just described, it sounds like they'd be centered at the clinic, or?
So I think these could move out of the clinic. I'm sort of partial to trying to study it first and making sure it's effective and meaningful in this context, and then starting to scale up. There's always a tendency in research to sort of be, I just discovered this thing, and then go on to your next discovery, versus trying to think about how to scale up and how to do this over and over again. So what I'm interested in is, first of all, thinking about how we improve systems and do that in a systematic way, and then thinking about, in that context, how can you develop a series of interventions. So from that process map, we did one thing, which was we changed the whole intake process for patients, so that when you call, your patients have all the information they need for their visit. And so that seemed to be an important choke point. And then the next one was this counseling. So I'd love to see all of those things kind of scaled up in a clinic setting. And then the next piece would be, well, what if this worked outside of a clinic setting? So if I'm sitting at home and I'm kind of afraid to go into a clinical environment, I could start to learn about these methods in advance. And this will be really important with healthcare reform because suddenly lots of people are going to have insurance. They're not necessarily going to know how to interact with the medical system. So this idea of adding things like peer counseling and things that people can do self-education before a clinical visit, I think that would be great. So, and that's sort of the advantage of doing this in a technological way because the spread is so much easier than if you think about what can I do in just a clinical setting. And so working directly with women, allowing them to get information if they need it is really possible.
This is maybe a little bit more technical question, but as you're thinking about moving it out of an app that's on an iPad that you actually hand to someone in the clinic and make it maybe more accessible, are you thinking you would want to stick inside the different app stores, or would you be going to a website?
Yeah, so I thought about a couple of things. One is I've thought about having a website kind of as a backup. It's sort of, it's one of those things where I feel like if I say it enough times, maybe someone will make it happen with me. I'm always like, could we just do like a whole adolescent site where, when there are adolescent sites, they just don't always speak to urban youth of color, and they're not always taking in their perspectives into account. And so we do so much work where we actually integrate young people into the work that we do. I just think, well, they should be the ones who help us design this website, and it becomes kind of a backup. So what if you started with the app, and then if you wanted to take a deeper dive into something, you would be able to go to the website. And then also there's just this role for, I talk to so many young people, and they come in and they tell me all the things that they learned on the internet, and then, I was like, well, got that kind of wrong. So, there's also this role for having human interaction when you need it. So that would be sort of the other piece, is if there's some way to add some type of chatting or some other type of resource.
You mentioned the holy grail that you'd like to move toward. While you're examining the single problem of teen pregnancy and understanding that's the problem you need to address and isolate, will you take or try to have more influence on the education about STIs, or is that something you kind of have to step back from and hope the normal educational consultation will help there?
No, and in fact, what we're finding is that these two worlds are very siloed. So, and yet they're interconnected. So, what we think is that it was the HIV message among young men that drove up condom rates, which is one of the key reasons that teen pregnancy rates have declined. There's also been a new array of contraceptive methods available, so it's multiple factors. We also started moving towards comprehensive sex education, so there have been a lot of things. But right now, teen pregnancy rates are or birth rates are as low as they were in the 1940s, like huge. And the rates of HIV have really decreased, but gonorrhea and chlamydia are still really high. And so before you take we pat ourselves on the back and say, job well done, we have to really focus on STIs. But what we notice is that people come for these family planning visits and they're so contraceptive focused. And what the HIV world has done is they've focused on risk reduction. So they actually give a very complex message where they say, condoms, regular STI testing, if you can't do that, at least have a single partner. If you can't, really sort of saying there's a whole spectrum of behaviors. Those are very hard counseling messages to do in the short clinical time span that we have. The contraceptive methods that you can see, there's so many of them. They all have risks and benefits. So the challenge isn't that people are not doing a good job in healthcare provision. It's just a lot of information in a very limited amount of time, and we haven't completely understood the best way to do that. So that's kind of what all of this is about, kind of working out how you can create both of these things at the same time. So I've submitted 2 proposals to try to do that, but maybe the idea is just keep fixing the app, keep changing it and moving it forward and trying to do that in kind of smaller pilot testing ways. Okay, now I'm challenged, I'll do that. but so that's sort of why it's such a complicated thing, and as long as STIs and pregnancy have been around, we still haven't gotten it quite right. And then, the funding lines for HIV have often been separate from the ones for teen pregnancy prevention, and it's just, we get in our siloed
Well, it
hats.
seems difficult that like your most effective birth control method doesn't protect you.
Right.
How that's a difficult message.
And so what we say is, just because your toaster doesn't make coffee doesn't mean there's a problem with your toaster, right? It's just you need both a toaster and a coffee maker. And so that's the hard messaging, and that's where we're sort of thinking, try to take some of these complex messages, simplify them, but then give people adequate time to experience them in a form that they're used to.
Thank you.
So don't forget the mobile app challenge judging, which will be on May 30th at 1 o'clock. At 3 o'clock in booth on the first floor. And thanks to Melissa for being willing to talk with us. All these talks from the mobile app challenge colloquium are available on video, and you can go to, what's our URL? appchallenge.uchicago.edu, and you can see the videos and share them with your friends, and we'll be doing more of them. Thanks.
Thank you.